Hi, this is Christy O'Day, and we are going to talk today about family planning. For those of you who are going to Guatemala, this is an extremely important topic. Many of your patients will be women of childbearing age, and this will be one of their major health issues that you ought to discuss with them. So, our objectives today are first to talk about the importance of family planning within the context of the healthcare system. We're also going to talk about the different methods of family planning and how they relate to use in a low resource setting. We'll talk about some common reasons for not using contraception um, and some common barriers to family planning use. We'll also read an article about some new innovative ways of delivering family planning in a community based setting. And finally, you'll watch a video that identifies adolescents as a really high risk population when it comes to contraception. So, this slide is from the Guttmacher Institute, which is an organization that does research and advocacy in the areas of family planning and women's health. Um, First, we want to kind of talk about why family planning is so important within the context of public health. We know that across the world, in low and middle income countries, about 885 million women of reproductive age want to avoid a pregnancy. Unfortunately, 214 million of them, or about 25% of them, are not using modern contraception for one reason or another. 25% of women who want to avoid pregnancy are not using contraception. So, why is that? And what difference does that make in our healthcare system? Well, first of all, we know that if there are this large number of women that can't get contraception or are not using contraception, that has a ripple effect on the entire healthcare system. Those that 25% of women that are not using contraception, many of them are going to get pregnant. If we could provide contraception for that 221 million women, we could prevent 67 million pregnancies, 23 million fewer births, 36 million fewer induced abortions. Because maternal mortality is so high in many of the countries that we're talking about, we would save almost 250,000 women's lives and 2 million deaths and newborns would be averted. So we consider family planning a best buy in public health because we know that for every dollar we spend in family planning, we're going to save over $2 in the future in maternal and child health services. So, where are we seeing the most unintended pregnancies? Well, Sub Saharan Africa has the most unintended pregnancies per capita. So, over 100 unintended pregnancies for every 1,000 women of childbearing age is occurring in Sub Saharan Africa. However, we're also seeing really high rates of unintended pregnancies throughout Latin America, as well as the Middle East. And it is not negligible in many of the, quote, more developed countries like the US, Canada, and Australia, where we're looking at about 40 to 50 unintended pregnancies. So that's about 4 to 5% of women age 15 to 44 will get pregnant with an unintended pregnancy each year. So, since many of you are going to Guatemala, let's look at some of the data specific to Guatemala and to the Central American countries. So, when we look at Central America in total, we see that about 70% of women are using some type of contraception in Latin America. and 63% are using a modern contraceptive. And when we talk, the difference there between total and modern is those traditional forms of contraception, like the withdrawal method or rhythm method. So when we look at Guatemala in comparison to other countries in Latin America, we see that it's much lower. And the total contraceptive rate in Guatemala is only 54%, and the modern contraceptive use rate is only 44%. And these numbers are significantly lower than the other countries in Latin America or Central America. So this is just kind of an overview of the different methods of contraception, and this is a common patient educational tool that we use when we're talking about different forms of contraception with women. So our point here is not to go through each of the different forms of contraception and how they work. That's kind of outside the scope of our discussion today. I would encourage you to look that up if you have questions about that. Our purpose today is to kind of think about how each of these methods are useful or what their barriers might be in low and middle income countries. So the nice thing about this tool is that it shows the most effective forms of contraception at the top, including the LARCs and sterilization, and then shows the least effective at the bottom. So this table just kind of breaks down some of the benefits for each of the types of contraception and the potential disadvantages. Sterilization and LARCs are both quite effective and therefore can be very beneficial in low-income countries. They also require very little maintenance. So obviously once you have a tubal ligation or a vasectomy, there's not a lot of further maintenance or visits to the health center for that. And the same goes for LARCs. So IUDs are good for between 5 and 10 years, depending on the type, and implants are usually good for about 3 to 5 years. So those options are probably the most beneficial and the most recommended in these low resource settings because there's such little upkeep and maintenance that makes their costs relatively low, and they are obviously very, very effective. For the LARCs, they're easy to place, and in many, many settings, these are placed by nurses, and partners do not necessarily need to know that they are present. Now, the disadvantages for sterilization are, first of all, that they do require, for a tubal ligation, it usually requires anesthesia and an operating room, and therefore trained personnel, usually a surgeon and anesthesia, in order to perform it. Those are not as necessary for a vasectomy. However, in many parts of the world, there's a lot of cultural issues related to a vasectomy. And there may be cultural concerns, honestly, for every single one of these types of contraception, but in particular for a vasectomy. In Latin America, there is not a lot of use for those. For the LARCs, there are side effects related to them, and they may not be culturally acceptable, but in general, they are generally well tolerated. For oral contraceptives, they can be really easy to prescribe. They're effective if used correctly. You're going to read about in an article where pharmacists can dispense those without a prescription, and generally a partner doesn't need to know that a woman is using those. So those can be some benefits. Now, they can be relatively more expensive in comparison to the other LARCs, and they're not as effective if you don't use them or take them every day. Injections, things like Depo-Provera, again, can be quite effective. Partner does not need to know that a woman is taking them. And in fact, in Guatemala, Wukukuak has little clinics in patients' homes, and then the women from the community go visit that patient's home to get their injection every 3 months. The side effects you probably know about, they can cause quite a bit of weight gain. And it does require those every 3 month visits to a health center or a site to get that injection. The barrier methods are relatively inexpensive. However, there can be some cultural issues to using those, and they're not as effective. Traditional methods like the rhythm method or other fertility awareness methods may be more culturally acceptable, but may not necessarily be as effective and may not be as useful for each patient if they do not have regular cycles. So, what we do find is that it's really important for women to have options for their contraceptive use. So, in a place like United Kingdom, where all options are available to women, we find that about 84% of women use a modern method of contraception, and we see that many women use sterilization as well as oral contraceptives, as well as LARCs. There's less use of injectable contraceptives. However, in other countries that have less resources, we see that there's less use of sterilization and higher use of injectable contraceptives. And that is probably related to access issues to sterilization. So, again, there was a good study published in 2014 about reasons for non use of contraception and unmet need in low income countries. And by far, the most common reason that women don't use a contraceptive, even though they don't want to get pregnant, is because they're afraid of side effects or the risks related to the contraceptive method. I find this really interesting and maybe related to a lot of misinformation that women have or myths that they believe about types of contraception. Other common reasons for not using contraception include infrequent sexual activity, again, and also a very common reason for unintended pregnancy, postpartum amenorrhea or breastfeeding status. So in Guatemala, we recommend that for the first 6 months after delivery, if a woman is exclusively breastfeeding and not having periods, she can rely on that for contraception. But after 6 months, we recommend she take something else for contraception. Less common is an opposition to contraception, whether religious or cultural. Contraception can be inconvenient. You have to go to the clinic to go get your shot or to get pills. Subfecundity means that a woman thinks she probably can't get pregnant because she hasn't gotten pregnant. But what's becoming less and less common is the lack of awareness that contraception exists. So almost all women know that contraception exists and is out there, but that is not usually the reason for not using it, interestingly enough. So a quick word about spacing. Interpregnancy interval is that time between delivery and the start of the following pregnancy or conception of the following pregnancy. And our goal in general is at least 18 months for that interval. So we know that women who have an interval of less than 6 months are more likely to have a preterm delivery or a baby that is small for gestational age. And that is Risk is also seen when that interval is between 6 and 18 months, but much more common and higher risk if the interval is less than 6 months. This data is based on studies done in the US, and so we believe that the risks are much greater in lower resource settings where the nutritional status of women is going to be much poorer. So, knowing all now that you know about reasons for not using contraception, what is the recommendation? Well, the recommendation is just really more information and education for women. And so the way that we translate this into clinical care on the ground in Guatemala or wherever you're seeing patients is that I encourage you to ask every single woman of childbearing age about her pregnancy intention. Frankly, I recommend that you do this in the US as well. And I do this with all of my patients in the United States as well. But we really highly encourage you to do this in Guatemala. I encourage you to ask the question, are you interested in getting pregnant in the next 3 months or having a baby in the next year? And if the answer is yes, then ask a few more questions. Ask about spacing. When was their last delivery? Talk a little bit about spacing, and then offer preconception counseling. Talk about how important it is to get your body healthy and ready for the next pregnancy, including good nutrition and taking prenatal vitamins. If the answer is no, ask the patient if she's using any form of contraception. And you may need to kind of list off what we mean by contraception. And if she's not using any form of contraception, then offer her some patient centered counseling regarding the options. I would encourage you to ask her, what have you used before? What have you heard about? Is there a particular form that you're interested in getting? In general, I think the LARCs are a really good option in Guatemala, and both implants and IUDs are offered by Wukukuak. And so I would encourage you to talk about those with the patient. So that brings us to the conclusion of this PowerPoint. I just want to share with you two more pieces of this family planning module. First is a great article talking about some innovative new ways of delivering family planning in a community that helps overcome some of the barriers to accessing family planning. So please read that article that is on the website. And then I encourage you to watch the video, The Girl Effect. You can click on that little link and it'll take you right to it. The leading cause of death for girls and adolescents ages 15 to 19 is childbirth. And we know that the highest contraceptive unmet need is in adolescents ages 15 to 19. For those girls, we see also that there's a much higher mortality from childbirth, maternal mortality rate in adolescents. So this is really a big piece of the puzzle as well. So I encourage you to watch that video. And after you've watched the video and read that paper, there's some other resources on the website. Please go ahead and take the quiz. If you have any questions about any of this, please feel free to contact me by email. Thanks. Have a great day.